The broadcast is now starting. All attendees are in listen-only mode.
All right, Dr. Fertig, soldiers.
Are we ready?
You ready, Dr. Fertig?
Okay, good. Hello, my name is Evan Fertig, and I'm the Director of Research for the Northeast Regional Epilepsy Group. And today we're going to be talking about the research going on in our program. We're also going to talk about some new exciting therapies. Here is the agenda of what we'll discuss today. We're going to talk about why epilepsy research is important. We're going to talk about what is a clinical trial, and we're going to talk about epilepsy medications under study at our group and medications that were recently approved. We're also going to be talking about new surgical treatments for epilepsy. So I'm going to talk about a case which is going to illustrate the work we're doing. The names and ages of the patient were changed, though, to protect the innocent. Bill came with me to his parents for a second opinion. This is a 15-year-old young man. He had seizures which occurred every month, and he had severe falls with these seizures that would result in injury to him. He was also on multiple seizure medications. And because of side effects from all these medications, he was doing very poorly in school. So his quality of life was very poor. More about him. He had a video EEG test which showed that he had a focal seizure activity with seizures coming from his left leg area. He had an MRI of his brain, so that's neuroimaging, which showed a pocket of abnormally developed brain tissue in his left leg area in the frontal lobe of his brain, again on the left side. So what's Bill's diagnosis? Well, in conclusion, Bill has focal epilepsy with seizures arising from an area of abnormally formed brain in his leg area. This explains why he falls when he has his seizures. His leg becomes weak. All right. He's failed multiple anti-seizure medications, and other options besides medications need to be considered, especially since he falls repeatedly with the seizures and injures himself. Because of all the seizure medications he's taking, he's tired and he's doing very poorly in school. Epilepsy surgery was considered. Unfortunately, a neurosurgeon can't remove this lesion because it would cause paralysis of his leg. So we had to think about something else for him. And so what happened? Well, fortunately, at the time I was seeing the patient, I was working with a company called NeuroPace on a clinical trial with what we call responsive neurostimulation. In this trial, a device is implanted over the seizure focus without removing it. The device is programmed to detect seizure onset and then delivers a small electrical jolt to stop the seizure buildup. Our team determined he was an excellent candidate for this NeuroPace. The risks and benefits of the study were discussed at length with the patient and his caregivers. And after much discussion, they agreed and signed an informed consent form, and they proceeded with doing the study. You know, he's had the device in for several years, and we've had recent updates. He continues to do very well. You know, immediately after the procedure, the seizures became much milder, and he no longer was falling with the seizures. Because his seizures became much milder, we were able to reduce his medications. With fewer medications, he had less side effects, and he did much better in school. So overall, it was a very successful outcome. So just you know, progress in epilepsy treatment, this case illustrates it really requires teamwork between patients and researchers to find new effective therapies that requires a joint effort on part of the treating team and patients and families. Not every patient will do well as this patient in clinical trials. Our job as epilepsy researchers is to make sure that we explain the risks of new therapies carefully to patients and families. When they decide to participate, our job is then to conduct the trial properly and monitor very closely for any potential side effects from the treatment. Also track seizures very closely to determine if a new treatment works or not. I want to emphasize that patients and families who decide to participate in clinical research are playing a major part in making new treatments possible. Without their support, progress in epilepsy treatment is virtually impossible. So by participating in epilepsy research, you allow us to better understand the causes of epilepsy. And with a better understanding of the fundamentals of epilepsy, the better our treatments will be. And again, I can't emphasize this more, but the key for progress in with developing new therapies is really teamwork between patients, families, and medical doctors and researchers. So let's just go over some basics to illustrate what I'm talking about a little further. This may be a review, but epilepsy is a condition where the brain's electrical system is overly excitable and prone to electrical storms we call seizures. By definition, someone has epilepsy if they have 2 or more seizures. How do neurons, brain cells, work? Well, brain cells, again, neurons, are like telephone cables. Messages come in one side, travel down the wire, and then are released on the other side to talk to other brain cells. On this other side, there are special proteins called ion channels which help with the communications. There are multiple different types of ion channels. Some ion channels, like sodium channels, are excitatory. They excite other cells, where other ion channels, like potassium and different types of channels, are what we call inhibitory. They cause other cells to rest. So what causes seizures? Well, something might irritate the receiving end of the neuron, like a scar or a brain tumor or anything that irritates the surrounding brain. And that will cause the neuron to fire too much. Or there might be a problem with the sending or receiving end of the cell in the ion channels. In the end, excess firing will cause an electrical storm, and this results in seizure activity. Well, how do seizure medications work? Well, they usually work at the level of the ion channels. Either they block the channels, which cause excessive firing, or they encourage channels which block excessive firing. For example, carbamazepine, which is abbreviated CBZ on the slide, blocks the excitatory sodium channels. On the other hand, medication like gabapentin opens chloride channels, which encourages brain cells to rest. Well, what are the limits of medical therapy? Fortunately, for most patients, there aren't limits, and our current medications will work. Unfortunately, it's a process of trial and error, because every patient is different. Every patient will react different to medications. Unfortunately, it's a process of trial and error, because we don't know until we try which will be the right medication, because medications act at different receptors, and for each patient we don't know which are the right receptors to open and the right ones to block. Another problem is side effects. You can get side effects in the brain, because when you use these seizure medications, if you're using high doses or combinations of doses of medications, you may end up blocking too many neurotransmitters and channels, end up disturbing normal brain function, and that causes sleepiness and dizziness, what we call side effects in the brain. Also, seizure medications may rarely unintentionally affect other parts of the body besides the brain. For example, older medications like Dilantin and Tegretol over the very long term can cause painless thinning of the bones, which we call osteoporosis. That's different than arthritis, and that painless thinning of the bones can result in fractures of the bone. About fortunately, 2/3 of people with epilepsy will respond to medications, but that leaves 1/3 of people with epilepsy who have what we call drug-resistant epilepsy. The definition of drug-resistant epilepsy is where seizures keep occurring despite 2 good trials of anti-seizure medications. A good trial of seizure medications, that means that an appropriate medication dose was used for the patient's epilepsy and appropriate dose was achieved. The medication failed because of persistent seizures and not side effects. How do we move forward? How does progress happen? Well, new targets for treatment are identified from animal research or other studies like families with epilepsy, and we identify their genes. And then researchers then find drugs which they suspect may help, quote unquote, hit these targets and stop seizures. Then the next step is to do clinical trials in patients to show the medications are safe and effective for epilepsy. I'll try and go back. If these trials are successful, then the government, what we call the Department of Government is the Food and Drug Administration, approves them for doctors to prescribe to the public. Let's talk a little bit about clinical trials. What is a clinical trial? Well, these key terms are derived from the Epilepsy Study Consortium. Clinical trials are carefully planned studies that will help determine important information about a new therapy. When we do a clinical trial, we test a new therapy, and we use doses that we select ahead of time, and we pick a time period which we think will be informative, and also the outcome of the treatment we're looking for. Usually we follow seizure frequency and the severity of seizures, and also frequency of side effects and the safety of medications. These are all very, very carefully measured. These clinical trials provide information which we then present to the Food and Drug Administration to make a decision whether the drug should be approved for use. And when we say approved for use, we mean, will it be made available for doctors to prescribe to their patients? So some other key terms: randomization and control. In a randomized trial, subjects are assigned to one of several possible therapies, and that occurs by chance, like by a roll of a dice. And randomization ensures that the outcome of the study is not going to be affected by the researcher's bias. Each therapy option is called an arm, and each study can have multiple arms. Some of the arms will contain different doses of the drug. And sometimes the trial arms may contain different drugs. Often in one arm, patients will have no change in their treatment. These patients will act as the control against which the other arms are compared. And we say control is needed because seizure frequency might change over time by chance. So it's very important, that we know that the change is due to the drug and not chance. Blinding is another key term. Doctors and patients will react differently if they know which treatment they're receiving. So to prevent this, we blind the study so the subjects and the doctors are not aware of which treatment they've been randomized to. A placebo is a sugar pill. So we talked about the control arm before. So we give those patients what we call a placebo or sugar pill to help maintain the blood. What should you know before participating in a clinical trial? Before enrolling in a clinical trial, you should ask your doctor to give you information about the previous safety record of the study medication or device. Also, you should ask about the chance of getting an active study medication versus being in the control arm and getting a placebo sugar pill. You should ask, how long will the trial be? You know, that's very important, because if some people are getting the placebo, it would be unfair if they were getting it for a very long period. You should ask how long the blind will be. You should ask very carefully what you should expect at each visit, what tests will be performed, and you also should ask if you will have access to the study medication for free after the trial is done, and for how long. You know, very frequently with these trials, the patients will get the medication for free until the drug is approved or not. Let's talk about some promising new medical treatments under study at our site in the Northeast Regional Epilepsy Group. I divided our medical treatment research into two categories. One they call everyday treatments, or what we call maintenance treatments. These are treatments which are taken every day to help prevent seizures. On the other hand, emergency treatment given when there are unexpected breakthrough of seizure clusters or other seizure emergencies. Okay, first study that I'm going to talk about is a medication under study called Ganaxolone. This medication is based on a natural hormone in the body, and so it works very differently than all of our other current medications. It helps block excessive firing by opening ion channels which calm down brain cells. They're shown to be very effective in earlier trials with fewer side effects. So I was fortunate to participate in the earlier clinical trial with this medication, and my patients overall did very well. This is a study for partial epilepsy. It means partial or focal epilepsy means that seizures are arising from just one part of the brain. This medication is given as a pill twice a day. So in previous studies, Ganaxolone was shown to cause a 20% reduction of seizure frequency, and 25% of the subjects were 50% responders, meaning that they had a greater than 50% reduction in their overall seizure frequency. In terms of side effects, multiple animal models have been done, and it's shown to be overall safe. It's safe in nearly 1,000 patients who have been treated with this medication to date. And generally, the side effects are very mild, dizziness and sleepiness. So again, to summarize about this study, we're comparing this medication versus a sugar pill. And it's for the adjunctive treatment of subjects with partial onset seizures. Oops. Go back. The objective of the study is to determine how safe and effective this medication is in adults with partial onset seizures with poorly controlled seizures. The requirements, this is a brief summary. There are more selection criteria, but the basic ones are we're looking at adults only who are older than 18. They can be on 3 or fewer anti-seizure medications, and they have to have 3 or more seizures per month. The study procedure is visits to the Hackensack office. We can give you more details in our informed consent if you're interested. All medications Visits are provided for free, and patients receive a stipend also. The second medication that's under study at our site is a medication that has a code name because it's under study. It's called YKB 3089. This is a very exciting therapy. The mechanism of action of this medication is also thought to be different than all of our current treatments. So it's possible this medication will work for some patients who medication hasn't worked for in the past. This medication is thought to block the excitatory sodium channels and open other channels which calm down brain cells. This is also a study for treatment-resistant partial epilepsy, and the medication is given once a day. The medication is been shown to be very effective in one earlier study. A significant number of the patients were greater than 50% responders, and there was a major reduction in the overall frequency of what we call grand mal seizures. I abbreviated that, generalized tonic-clonic seizures. Earlier work in animal models also suggests that this medication is very safe. And about 400 patients have been treated to date, probably more at this point, and it appears to be a very safe medication. In terms of side effects, there are very few and very minor, nothing permanent. So here's a summary of the trial. Again, we're comparing this medication versus placebo in patients with partial onset seizures. Basic requirements, we're only looking at adults older than 18, need to be on 3 seizure medications and having 4 or more seizures per month. That's the basic summary. There are more, again. Study procedures, visits to our Hackensack office. All medications and visits are provided for free, and there's a stipend. So Lacosamide or Vimpat is another medication under study. You probably heard of this medication because it is approved and marketed. So you may ask, why are we studying this medication when it's already available? Well, a lot of times more research is needed after a medication is approved to learn some other unanswered questions. For example, how can doctors use it more safely and with fewer side effects? Also, can it be used safely in other populations which haven't been studied yet? For example, Vimpat was approved for adults. Studies are being done to see if it can be safely used in kids. So here's a study that we've been doing, which is going very well. This is looking at the cognitive, which is thinking, and behavioral, which is mood, effects of lacosamide for partial onset seizures. And this is being organized by the head of our program, Dr. Marcelo Lancman. So as you know, this is a medication which is approved by the Food and Drug Administration for the treatment of refractory focal epilepsy. From our experience, it's a very effective medication with few side effects. We're looking more closely to see how this medication affects thinking and concentration and mood. The requirements for this study are age 18 or older, English speaking or balanced bilingual, meaning English skills are very good, 2 or more seizures per month. There are other requirements, but those are the basic ones. Visits are to the Hackensack office over 36 weeks. All medications, visits, and neuropsychological testing are provided for free, and patients also receive a stipend. What other studies are we doing with this medication? We're also looking at this medication in children. As I said, this medication was only approved for adults. I am the head of this study. We're looking at both focal and generalized seizures in children to see how safe and effective this medication is. The age requirements This is a basic summarization again. 1 month to 18 years are included, but it's actually different for focal or generalized seizures. So you'll have to contact us for more information about that. But the requirement is 2 or seizures per month. Visits to the Hackensack office occur over a period of greater than a year. All medications and visits are provided for free, and patients receive a stipend. I'm also doing a study with a medication called Lyrica, which you heard. I'm very interested to see if it has an additional effect on anxiety in patients with partial onset seizures. The requirement is that patients are greater than 18. They're on 1 or 2 anti-seizure medications and not presently treated for anxiety. Our suspicion is that this medication will be helpful for both epilepsy and those patients who have both. Anxiety is very common in patients with epilepsy. So visits to the Hackensack office over 6 weeks. All medications, visits, and travel are provided for free, and there is a stipend as well. Sorry. Coming down the line, Dr. Segal, he's the pediatric epileptologist for our program, and myself will be doing a study with a marijuana derivative called CBD for children with severe refractory forms of epilepsy. So just going to shift gears a little bit. I'm going to talk about a completed study and a new medication which is available. Aption, which is ethylcarbazepine acetate, was a medication that was under study by our site and other sites throughout the world. The U.S. Food and Drug Administration approved this medication for adjunctive treatment of partial onset seizures. That means with other treatments. It's going to be available in multiple dose forms, and it's expected that this medication is going to be available soon. Again, this is a medication that will be for partial onset seizures. It's going to be a once-a-day medication. The bottom line is it's very similar to carbamazepine, but it's thought that it will be slightly more effective and better tolerated. It has a similar side effect profile to carbamazepine in that it rarely will cause rash, very rarely will cause liver abnormalities, and it can cause low blood sodium. Now I will shift gears again, and I'll talk about emergency treatments, which are under study. Again, this is not approved yet. These are study medications. You know, right now, in terms of emergency treatments, we really only have rectal diastat. Diastat is a very good option, but unfortunately, it's really our only one. It's clinically proven through research to work, but for bigger kids, teens, and adults, it has some limitations. It is harder to give since it's harder to undress a bigger person, and that takes time. It could also leak out of the rectum. Teens and adults might not like getting undressed by someone in public. Also, you really can't self-administer it. We're doing a study with an emergency treatment called midazolam, which is Versed, which is given in the nose. The advantages are it's much easier to give. It is a much preferred route for patients. It can be self-administered or given by a caretaker. Currently we have it under study. So in the intranasal midazolam study, our objective for this study is How safe and effective is intranasal midazolam for seizure clusters? The requirement is that the patients need to be age 14 to 22 and have seizure clusters. There are many other inclusion criteria, but those are the basic ones. This study requires one visit to Hackensack Hospital for testes and then follow-up visits. Travels and medications are provided for free. Okay, so now we're going to talk about surgical treatments. What are the limits of surgical treatments and what's on the horizon? Well, first of all, when do we consider resective epilepsy surgery? And when I talk about resective epilepsy surgery, I mean we're taking out a part of the brain tissue. We're taking out part of the brain tissue to remove a seizure focus. We only consider this for treatment-resistant partial epilepsy, which I defined before, failing multiple, at least 2 seizure medications. And, patients may have failed medications and they may be just having multiple side effects from medications. Why do we consider epilepsy surgery? Because we know after 2 failed attempts at medical therapy, the chance of future success is low, and the chance of injury over a lifetime of seizures is high. Epilepsy surgery is usually safe and effective. How does epilepsy surgery work? Epilepsy surgery works by directly removing the lesion, which is irritating the surrounding brain tissue and causing seizures. Here's an example of the most common form of epilepsy surgery, a temporal lobectomy. There's a scar tissue on the right side, which is resected, removed. I won't go over this today in much detail, but the chance of seizure control is very high for different forms of epilepsy surgery versus medication. And the success rate is determined by the type of epilepsy surgery and what it's being done for. What are the limits of epilepsy surgery? Well, as I said, overall epilepsy surgery is very commonly performed. It's usually safe, other than a small risk of bleeding and infection. It is not effective, though, for all seizure types, and it is not useful if seizures are coming from multiple or poorly defined areas of the brain, or from critical brain tissue areas like the leg area in the case that we discussed. Visualase is a new minimally invasive form of epilepsy surgery using laser therapy, which we're working on. This is currently under study at our sites. Our study is called A Study to Prospectively Evaluate the Effects of MR-Guided Laser Ablation in the Epileptogenic Foci in Patients with Treatment-Resistant Partial Epilepsy. The advantages of Visualase is that we can avoid a large open brain surgery. The surgery instead uses a probe like a biopsy. Here is how the procedure will go. The probe is inserted in the operating room. The patient is then transferred to the MRI machine at Hackensack. The treatment is then given under observation with an MRI, which we can real time we can monitor the laser treatment and ensure that it's being delivered safely and not injuring by accident areas of the brain which are not involved by the seizure focus and are of critical nature. After the laser treatment is given, the probe is removed. Frequently, the patients can leave the same day after this biopsy-like procedure. We just did our first case The patient tolerated it extremely well without complications. He had very few side effects, and he's very happy with how it went. It's too early to tell how well the patient's seizures are controlled, though. The composite data from other centers, though, looks like it's very promising and is probably going to be equivalent to the standard temporal lobectomy. Another strategy which is being developed is called neuromodulatory treatments. This is where a device is implanted not to destroy brain tissue, but to alter its function. A whole range of treatment possibility exists, including electrical treatments, like we talked about NeuroPace, focal cooling, or delivery of medications locally to the seizure focus. The advantage of neuromodulatory treatments, it may limit those unintentional body side effects and brain side effects from medications. And it also holds the potential of improving brain function. We talked about NeuroPace already, which is this device was actually recently FDA approved based on the studies. And I talked about that in terms of Bill's case. Again, just to summarize, the device is implanted under the skull and has electrical leads that lead to the seizure focus. These leads pick up brain activity, and they learn to detect seizure onset. And then electrical treatment, like a little jolt, is delivered to arrest the seizure buildup. At each visit, the MD reviews the brain activity and the seizures, and then fine-tunes the treatment. So what will epilepsy care look like in the future? Well, I think instead of picking medications on a trial and error basis, we will have personalized medical choices based on someone's genetic profile. And instead of medications which only suppress seizures, we'll have treatments which will address the underlying condition, the epilepsy itself, and its comorbidities like with depression. We'll also have treatments directed right at the seizure focus, like NeuroPace, to reduce the chance of side effects. To conclude, I think in most cases, fortunately, seizures can be well controlled with medications. That's for 2/3 of patients, with minimal side effects. Really, it's important to have a right diagnosis, the right type of epilepsy and seizure someone's having to properly guide their treatment. And also, I'd like to emphasize that epilepsy frequency is a condition where there's more than just seizures. There's comorbidities like depression, and treatment may require a team approach by doctors, by psychologists, and by other medical professionals. Some cases, though, are more difficult to control than others. And even with treatments like diet therapy or surgery, which commonly are very effective, for some they may not work. And I think in these options, we should always remember that clinical trials may be a promising option for some patients. So I just want to end by thanking you for your attention. Again, I'm Evan Fertig, and I'm the head of research for our program. And you'll see here the name and phone number of one of our clinical research coordinators. Her name is Dr. Manasa Malik. Dr. Malik or her colleague, Dr. Corazon, or myself will be happy to address any of your questions about our research studies. Please see our website for a complete list of our current studies. In conclusion, have an excellent night.